should be presenting. Katie, are you available?
Yes,
Okay.
thank you. I wasn't sure if MDRBD was going first. Thank you so much. So I'll be just sharing a little bit of updates for the reporting from the HRSA required reportings for PMHCA awardees for 2018 and 2019 and ART PMHCA awardees for 2021. So first, for 2018 awardees, we wanted to thank you for submitting your federal financial report last month, and just wanted to remind you that the prior approval request for carryover is due within 30 days of the federal financial report submission. And then thank you as well for submitting your NCC performance report and that request for information that were due last week. Those are currently under review by your project officer. And we will just expect to hear from your project officer with any requested changes as they undergo that review. And then looking ahead, the NCC progress report for 2018 awardees, that is due mid-June, approximately June 16th. And then for 2019 awardees, you have an upcoming report due for the NCC progress report that is due March 17th of this year, and including and the instructions for that will be uploaded in the next week or so be on the lookout for that. And then the next NCC performance report and request for information will be due later this year in October, at the end of October. And then the federal financial report will be due October 30th as well. And again, that prior approval request for carryover will be due within 30 days of the federal financial report submission. Next slide. And then for 2021 awardees, first again, thank you for submitting your first required reports, the new competing performance report and the request for information for baseline data. So those were due last month, and thank you all for completing those. Those are currently under review. You may have heard back from your project officer at this point, but if you have not, those are undergoing review now, and you should be hearing back whether or not that submission was accepted as is, or if there are any needed edits or clarifications. And then looking ahead at upcoming due dates, the non-competing continuation progress report. So that first progress report is due on June 16th approximately of this year. And this report includes project accomplishments, progress towards goals and objectives, staffing updates, technical assistance needs, subcontractors, linkages with programs, impact, diversity, health equity, a detailed work plan for the upcoming year, advisory board activities, information on telehealth referral database, and sustainability efforts. And all of that is outlined within the reports and measures document of what's required within that progress report. And then later, the first federal financial report will be due next January of 2023. Next slide. And then just wanted to speak a little bit to the general data template, just some reminders, since we are undergoing some changes, particularly for the 2018 and 2019 awardees. So for 2018 awardees, the additional required measures outside of the performance reports that we collected through the request for information, that'll be in the general data template. And just please note that there are a couple different versions of the general data template for the 2018 and 2019 awardees to use. So the 2018 awardees are currently in year 4 as of September 30th, 2021. And you should be using the June 2021 general data template for this year. And then for year 5, your final year performance reporting, that reporting period begins in September 30th of 2022. You'll be using the December 2021 version of the general data template. And then for 2019 awardees for year 3, starting in July 1st, 2021, you'll be using the June 2021 version of the general data template. And then for year 4, your final year of the period of performance starting in July of 2022, you'll be using the December 2021 version of the general data template. And all of these versions of the general data template are located on our performance reporting website and under the tools and resources, and we'll link that in the next slide too. And then for all awardees, as a general update, we'll be updating the instructions within the general data template. The measures will stay the same, but we will be adding some additional guidance and clarity to those instructions. And that's based on, undergoing this first round of baseline data collection for our PMHCA 2021 awardees. So thank you all for your feedback and questions. Those are helping to guide some clarifications within our guidance. And we'll be updating those instructions and sending those out well before the next round of reporting. So you'll have plenty of time to review those before you'll be required to report on those measures again. And if you have any questions about reporting for any cohort, please reach out to your project officer and we'll be sure to clarify and answer those questions for you. And next slide. Yes, so this is the link for the performance reporting page, just sharing our reports and measures document, which outlines each one of the reports and the due dates for all awardees. And then each version of the general data template, and Kara's sharing that link in the chat as well. So for 2018 and 2019 awardees, you can see the June 2021 and December 2021 versions of the general data template. And for 2021 awardees, you can see that December 2021 general data template version there too. Thank you. I'll pass it off to the next speaker. Thank you.
Okay. There you go, Mona-Lee.
All right. Thank you, Susan. Good afternoon, everyone. My name is Mona-Lee Belazaire, and I'm one of the project officers for the MDRBD program. That's the Maternal Depression and Related Behavioral Disorders program. And I'll be providing updates for the MDRBD awardees. Just want to highlight that as we are going through our reporting calendar year, thank you all so much for submitting your DGIS performance reports in your Form 10, as well as your first quarterly congressional justification. Just want you all to be aware of the upcoming deadlines for the second quarterly congressional justification, that is April 30th, the NCC progress report, that's June 16th, and the third quarterly congressional justification, that is July 30th, 2022. So just want you all to be aware of those upcoming deadlines. Once again, thank you all for submitting your information for the first quarter, for the first month, excuse me, of this year. That's your FFRs and your DGIS performance reports. If you do have any questions about the reporting timeframe or any questions about your submissions, please feel free to reach out to myself or the other project officer that's assigned to your portfolio. That's Sansi Furman. Next slide, please. Okay. Can you go to the next slide, please? Okay, sorry. If you could just go back, please. I think I probably submitted the wrong set of slides. Do I have the opportunity to share my screen?
Yes, I believe so. I think at the bottom, you should have a share screen icon. Do you see that? And you should be able to share. Let us know if not, though, if there are any.
Yeah, I don't.
Oh, okay. So let us see if we can grant you that privilege.
Okay, sorry about that.
Let's see. Nolan, do you know how we might allow Mona-Lee to share her screen?
Mona-Lee, in the meantime, if you want to email it to us, we can post it up real quick, but maybe Nolan can assist with this.
Yeah, no problem, sure. And I can run through it because the information that I'm sharing is not necessarily new to the awardees anyway. So I'll do it that way. Just want you all to be notified of the DGIS form That's a discretionary grant information systems form. So notification was sent out to both the PMHCA and the MDRBD awardee grantees, just notifying you all that the 60-day federal register notice outlining the DGS form updates, and that's for implementation for FY 2023. That was published.
Mona Lee, I'm just going to interrupt 1 minute.
Uh-huh.
Michael Battenfeld shared that it looks like maybe Alt-S might allow you to share. I don't know if you want to try that.
Yep. Okay. I think I'm okay. I'm good.
You should be able to share now.
Okay.
All right. Thank you.
Okay.
All right. Oops. All right, there we go. Yep. So as I was saying, so the Federal Register notice was published on the 21st of January. Comments are due on March 22nd. And so we are encouraging all of the PMHCA and the MDRBD awardees to submit comments on the DGIS form. Also note that the proposed changes are for both programs. And so we want to encourage you all to do so. As I'd mentioned earlier, that notification has gone out for both of the programs. If by chance you did not receive that, because that notice also has the link that goes directly to the site where you can make comments, please reach out to your project officers. Also want to notify you all that there's a change from the form being training form 14 to now training form 14. And finally, just want to notify you all, I know the MDRBD awardees know of this, but also wanted to provide the opportunities for the PMHCA grantees to know this as well, that HRSA has awarded a contract to Postpartum Services International to stand up the new National Maternal Mental Health Hotline. So that hotline will provide free 24-hour confidential support to pregnant and postpartum people and their loved ones. That's going to be via phone and text in English and in Spanish, and that's going to start this spring. Counselors will provide support that can include or range from evidence-based information, brief intervention, support groups, and community-based or telehealth providers. So once that hotline is officially launched, we'll share it amongst the listservs. I know both programs have a listserv, so we'll get that information out. And we certainly encourage you all to utilize it in your programs. Share the information as you're speaking with the providers. We want to get the word out that this maternal mental health hotline has launched. And we also want to make sure that it is being utilized by pregnant and postpartum people and their loved ones. And that is it for the presentation for MDRBD. Thank you, Susan.
Great, thanks so much, Mona Lee. Ashley, if we can share the original slide deck, that would be great. And let us just get back to where we were for the awardee program evaluation and data collection strategies and lessons learned. Perfect. Thanks so much. Well, great. Thank you so much, Katie and Mona Lee, for that update on the HRSA required reporting and for sharing about the maternal mental health hotline, Mona Lee. That sounds like a really great resource. So we'll look forward to hearing more about that. Awardees, if you have any questions about what Katie and Mona Lee shared, please just put that into the chat and we can make sure that we go ahead and give HRSA the opportunity to address those questions during the Q&A portion at the end of the webinar. But for this portion, my name is Amanda Gamerick. I am the Deputy Project Director for the HRSA MCHB evaluation. And we're going to turn to our discussion of awardee program evaluation and data collection strategies and lessons learned. Next slide, please. So, since this is our first time gathering as a full group for the HRSA MCHB evaluation capacity building webinars, we wanted to share this map, which shows all current PMHCA and MDRBD program awardees. As you can see, there's quite a wide spread of programs between the 2018, 2019, and 2021 PMHCA cohorts, as well as the 2018 MDRBD program awardees. So this just gives you a sense of who your fellow awardees are, which I know you saw in the chat today as you introduced yourselves. But for this portion of the webinar, what we did is polled the 2018 and 2019 PMHCA awardees, as well as the 2018 MDRBD awardees, with the question, what are 2 or 3 lessons learned or things you would do differently related to evaluating your program when looking back at the earlier implementation phases? We reviewed all the responses to this question and have grouped the responses by themes and sub-themes. Awardees who responded are going to share and expand on the responses that they provided to our question that we just posed. So we think this is helpful information not only for the awardees who have previously been funded, but also for the newly funded 2021 PMHCA awardees as you begin implementing your HRSA funded programs. So as you're listening to awardees share their strategies and lessons learned, please feel free to add responses, comments, or your own strategies in the chat. And again, we can discuss during the Q&A. So with that, I'm going to switch to our next slide, please, and introduce our first theme and awardee speaker. So the first theme that emerged from responses to our question was making sure that you're prepared for rapid startup of data collection processes and mechanisms. And we are first going to turn it over to Jen Fall from the North Dakota PMHCA program to share their experiences related to this theme. So Jen, we will turn it to you.
Hi, thank you, Amanda.
Sure.
For the first thing that we had when we got our grant in 2018, and then we started collecting data, we sublet some of our services out to contractual agencies. So our consult line, for example, we utilize Family Voices of North Dakota, who do a superior job for the program. But making sure all of the HRSA form requirements are like the demographics and other things that HRSA was needing was also included in their database, so that when it came time for reporting, we had all of the needed demographic kinds of data. We had what we thought we could support with the reporting process, but we fell short a little bit on some of the contractual pieces with information that they were able to give us right away for our 2020 reporting structure. We also used the University of North Dakota ECHO platform for all of our ECHO services that we provided through the last several years. And we didn't have exactly the breakdown of professional credentials. And so those were some of the reporting requirements, not just the number of attendees, the number of people that you were required in educating through each one of the episodes, but also knowing which ones were nurse practitioners or which ones were pediatricians or family practitioners. So again, knowing all of the necessary requirements, and after each time we've done a report, if there was any element that we've had a challenge with, our data team would go back to make sure that the data forms that we're using or the surveys that we're using to capture the data have been changed, so the next year we'll have that. And then again, making sure any of the changes that are coming out from HRSA, new forms created, that our data team is looking to make sure we have it covered in any of our current or existing forms, and that we're also subletting that out to our contractual agencies to make sure that they're able to capture that information for us for our reporting requirements.
Great, thanks so much, Jen, and really ties into those updates from HRSA around some of the reporting requirements that are happening, and really just being aware of that and making sure those are communicated to any partners involved. Thank you so much for sharing. And so then within that kind of broader theme, we had some additional responses, one of which was, and I think it ties to your response, Jen, is understanding HRSA required reporting before starting data collection. And so we are going to turn it over to Jim Beasley from the Rhode Island MDRBD program to speak to that.
Yeah, thank you so much, Amanda. And just building off of what Jen said from North Dakota, I cannot emphasize the importance of taking the time to look at your DJIS forms along with your performance measures and setting up those crosswalks. But do not start from scratch is the big advice. We're lucky in Rhode Island where we also had a PMCHA awardee, and they were started prior to the HRSA funds being awarded in 2018. So we leveraged their teleconsultation database collection forms and used other ones from like the Lifeline for Moms networks, which again is a perinatal sort of technical assistance network. And we crosswalked all of the forms, and it's something that's going to happen over time. I don't want to put undue expectations that you're going to hit it in your first run. You're not, because things change, but look at age, look at race, look at ethnicity, look at your health insurance stratifications, look to see if you have to cross-cut for the MDRBD folks about pregnant postpartum, depression level stratifications. In Rhode Island with our MDRBD program, we have cohorts, or we define our providers or enrolled providers as those who participate in a learning collaborative. So those change over time, but you also need additional functionality that aligns with the federal reporting parameter timeframe. So there's additional stratifications and customization that you're going to have to work with your partners to certainly get that. And I cannot stress again of trying to somehow, create some type of professional education outreach and sort of evaluation joint tracker between your partners, where you keep a running list that it's collectively sort of populated about when you've engaged with providers, what that type of engagement is and what those roles are, because it does get to that level of specificity. And also be very proactive with not just, I think what Jen was saying, very great about interacting with your partners before and after, but also reach out to your HRSA program officers. They're a great resource to help navigate some of these challenges, especially given some specificity and alignment that they're struggling with too, about just how to make sure that everyone's reporting in a very aligned manner. And so when in doubt, asterisk whatever you're saying, especially when it comes to directory reporting or your diagnosis conditions, especially with polysubstance use. You're going to see a lot of different what is nice to be collected, but not necessarily defined parameters of those measures. So when in doubt, do your best and sort of asterisk everything so that there's a running tally so your program officer can better understand it. But it's certainly an iterative process. And I cannot emphasize the need to leverage your fellow grantees on this call and your program officer, and you'll get there over time. It will make sense, but it can be overwhelming. So begin with the end in mind and don't reinvent the wheel.
Great. Thanks for that great advice, Jim. And I think it'll tie into some of our later responses as well as kind of leveraging those partnerships and relationships that you have. And also I like the idea of kind of making that crosswalk to make sure you're hitting all of those required data elements. So thanks so much for sharing. And then, so the second kind of sub theme within this larger theme was making sure you're setting up the infrastructure, so any databases, EHRs, whatever it is that you're going to use to make sure that you can collect those needed data. I think that element has shown through in Jen and Jim's responses, but would like to turn it over to Patricia Carrillo from Kansas MDRBD to share their program's experience as well.
Hi, thanks so much, Amanda. Appreciate this opportunity, and also wanted to reiterate what Jen said specifically about the level of detail being collected early on. I think we started with, especially for our training events, collecting some data from providers, and as the years went on, realizing that we needed more and more. And then also with the context of the last couple of years, our training platform switched from in-person to virtually, as I'm sure most everyone here has experienced. So that created some opportunities to better collect some measures, but also was just very different than the first 2 years when we were collecting data in person. But a little bit more context as far as KCC's implementation. And I think that infrastructure word hits the nail on the head. Our original infrastructure for collecting data and what our program implementation would look like looked very different in year one than it does today. We originally were using a phased pilot approach to implementation, working with 3, then 6, and then 10 counties in Southeast Kansas. We also were working with very established relationships in the early child care sector, building on some work that had been done on developmental screening. So that created a lot of wonderful opportunities with our public health folks, social services, but it was there was still a gap in our existing relationships with healthcare providers, which was a lot of really where we wanted our data to come from. So originally we and continue to have one really strong data collection system that's unique to Kansas called DAISY. Our Kansas Department of Health and Environment collects a number of different measures from their grantees through that system. And we were able to tap into that to get a majority of the data. But again, that system was very specific to mostly early childhood and public health. So we were focusing in that area and leveraging those relationships with providers while also trying to establish new ones with healthcare providers and physicians. And then also our access line didn't kick off until end of year one, but really strongly into year two. So that just delay in getting that set up obviously delayed some data that might have been collected if that had been implemented a little bit earlier. Additionally, we also have a perinatal access line, which became that grant was awarded, I think, a year after ours. So we originally weren't integrated with them. I think in a perfect world, in a do-over, we might have started that relationship earlier on and designed both programs a little bit more similarly. But again, our audiences were quite different. They're focused strictly on physicians. And again, we have a really broad provider type definition of folks that we provide trainings to. And then I think most recently, we've recognized a need or an opportunity to work really early on with folks who are either involved in utilizing EMRs and kind of that super user or other quality improvement staff within clinics. Oftentimes the kind of, nurse managers we're working with to implement things aren't the same folks who necessarily are going to be pulling that data. So just recognizing who's going to be the best person to have that conversation with early on, I think can get you started just a little bit earlier. And then Jim said another great word earlier, iterative. We had a really iterative approach to our enrollments, self-efficacy, and training formats, as well as incentives in our first 3 years, somewhat tied to that pilot approach. So I think a consistent definition of enrollment earlier on it is very helpful. And then also that self-efficacy, I think Lifeline for Moms got mentioned earlier. It was really a benefit working with that program and learning from some existing work that they've already put together. And then again, like I said, the infrastructure of recognizing what your data incentives might look like. I think making that decision early on is really helpful as well. And I know our project director, Kelsey Torres, is on. So Kelsey, feel free to add anything else.
Great. So many great tips. Thank you, Patricia. And I think, you mentioned the infrastructure, getting it set up early, making sure you're refining, tweaking, having those super users. I think there was a lot of great information in there, and it kind of, I think all of your tips are building on each other. So it's great to hear that some of the similar processes were helpful across. I know I'm seeing some chats already from interested newer awardees in some of your processes. So we'll make sure that we get those addressed during the Q&A. But around setting up infrastructure, we would also love to hear from Karen Burns from the North Carolina MDRBD program.
Hi, I don't have a whole lot to add. Jim and Patricia are right on in terms of our experience too here in North Carolina. I'll say for us, the only thing I would add is that in terms of setting up the infrastructure, our pediatric line came first. They had pilot funding 2 years before their HRSA funding, so they had a nice infrastructure set up already. We went into this kind of hoping to mimic what we had learned from MCPAP for moms and from our state pediatric program, and kind of realized very quickly in 2019, once we really hit the ground running, we had set up a whole data infrastructure, assuming kind of practice level engagement in our program, trying to go for more of a cohort model. And then around the time of the pandemic, we realized that was not going to work for our program. We weren't getting any buy-in at the practice level. We pivoted at the time of the pandemic to really focusing on provider level engagement and went statewide very quickly, kind of out of necessity, which was a complete 180 from what we thought we would do, which was very incremental, practice focused, county focused. So we went wide very quickly and then had to completely rethink our data collection efforts. We get a lot of users, we still do, from the UNC Health System, which we have access to the EHR, and we thought, oh, well, this is great. We'll just go behind the providers and pull all the data from the electronic health records, easy. It was not. So we realized there's just across a major health system, so much variation in how people are entering flow sheets. It still continues to be confounding for us in year 4, rounding the corner into year 5, how much inconsistency there is in terms of how providers are entering, their screening scores. And had we known all of that, had we predicted any of this in 2018, we would have gone down a completely different road. And it's been a lot of just backing up, meeting with our evaluation team again, figuring out how to get this data. So anyway, I say all that to say, I wish if we knew then what we know now, we would have gone about it a completely different way. What Patricia said about like knowing as much as you can in advance what your incentive structure is, who's going to be pulling that data for you, do they have access to it? Another big gap for us was state level data. We thought that data from the health departments would be where a lot of people on Medicaid get their health care. We thought that would be much easier to get. We were wrong. It's very hard to get. We still don't have it. So it's as much as you can know what you're looking at ahead of time, it will serve you later.
Great. Thank you, Karen and all. And I think, some of the main themes there were infrastructure, thinking about an incremental approach. I think you all kind of said that you kind of iterated and reiterated through what it might look like. I think leveraging partnerships, whether it's with existing PMHCA or MDRBD programs within your state, if they're existing, or just other community partners or data partners, was another great theme. I think, Karen, interestingly enough, your comment kind of feeds right into our next theme, which is kind of a implementation approach strategy, whether it's looking at practice enrollment versus provider enrollment or both. So you mentioned that you were thinking you would go kind of practice and go incrementally, but then ended up going broader than that. So I think that kind of feeds right into our next theme, which is thinking through provider and practice onboarding and engagement processes. So we would love to hear from Susan Griffin from Alabama PMHCA to share with us, and then Melissa Maris from Missouri PMHCA will share as well. So Susan, we'll turn it over to you.
Okay, thank you, Amanda. It's a pleasure to be here and to be able to share a little bit this afternoon. So I will say in Alabama, we have had a phased approach to implementation, which was focused really on recruiting rural primary care and pediatric practices. And we actually started with pediatricians exclusively and then expanded that in year 3 to include family practice groups as well. So we're not currently targeting urban practices, though we are in this year going to add a couple of urban practices to help us assess what our staff up needs will need to be as we get through year 4 and into year 5, when we really want to go full force with enrolling urban practices as well. I will say that in-person meetings with providers is so key, in my opinion, if you can do it. I started out visiting providers across the state. Typically, they would have me come at lunch, which was the only time they didn't have patients. And that has worked very well. It gives you an opportunity to meet their staff, to meet their practice managers, to meet them, to hear firsthand what their experiences are with children who have mental health needs and what some of their struggles are. And I think it helps you sort of tailor your approach to how you might help them. Certainly, we shifted to Zoom meetings in the height of COVID, but thankfully we are back to in-person meetings again, which is really one of the most enjoyable parts of my job because it really allows you to start building those relationships early. The other thing we did early on was partnering with our state AAP chapter, who helped us with our needs assessment survey in year one, and then throughout has helped us by promoting the program through their e-newsletters and their print newsletters. We've also exhibited at their state conferences twice a year for the last 2 years, and that gives us a gateway to a lot of providers on the site. And we've certainly enrolled practices from those state conferences. And it helps because your enrolled providers see you there supporting them as an organization as well. I've had providers come up to our booth and just say, thank you so much for being here and for supporting the work that we do. And that relationship building is just invaluable to me. I think it's really important early on to discuss in those meetings what's offered and what resources we can provide, but also what's expected of them as a participant. We utilize Project Echo to deliver our training component of the program. And we talk specifically about, we want you to use our consultation line. We have access to see patients by telemedicine if need be for more complex cases, but we really want you to participate in the training. We offer 2 training series a year, and letting them know that, hey, you can't really just use the consultation line and not participate in the training. That defeats the purpose of the whole program. And by and large, we get great participation in our training series. We have participants who joined in year 1 who are still coming to trainings now in year 3. So I think that's exciting and important too. And our care coordinator who triages our consult line, she really has built relationships with those providers, especially those who call regularly, and has built relationships with their staff. And I don't think that can be underestimated in terms of the importance. And I think the other thing that does, it also gets buy-in from them to not only participate and use the resources, but to also participate in things that you need them to do, like your evaluation efforts. Lizzie Taylor is on the call today too. She's a member of our evaluation team from the UAB School of Public Health. And I think she would tell you, and Lizzie, feel free to chime in if you'd like, she conducted some key informant interviews with our enrolled providers. And with 100%, she got responses just by sending out an email and asking them to participate in an interview. So that to me was remarkable that they all were in agreement to participate. And she's going to be doing another round of those key informant interviews this spring with newer providers who've enrolled in the last year and a half, and has also done a round of key informant interviews with caregivers and parents of kids who've been served by our program. So it just really helps if you can build those relationships to get that buy-in for the whole aspect of the program.
Great. So it sounds like a big key for your program, Susan, is that relationship building, whether it's through those in-person meetings where you're going out to practices and talking with providers, whether it's through that connection with AAP to reach out to a broad group of providers, or just anything you can do to kind of cement those relationships and get connection with your program. So
let me make one quick comment, Amanda. I'm sorry. The other thing we did was we used some of our carryover money to offer lunch and learns in the pediatrician office. So we brought lunch to their office and had a member of our team go and do some training. We also contracted with Alabama Partnership for Children in our state, who also provided some lunch and learns. Some of those were in person, some were virtual. So that was a big win too. People were really appreciative of that effort.
Great. Yes, that's a great strategy. Great. Well, we would also love to hear from Melissa Maris from Missouri PMHCA on this topic about kind of onboarding and engaging with providers and practices and what you've experienced in your program, Melissa.
Thanks, everybody. And hello from Missouri. I think the lesson learned that we wanted to highlight regarding this theme is perhaps obvious or deceptively simple or complex, but it's just the idea that when we are thinking about not just data collection, but also the program as a whole, that it's important to continuously think about whether we are engaging at the practice level or the provider level or both or more than regional level, health system level, state level. And so I think, from the beginning, most CPAP here in Missouri, we have enrolled providers and formally enrolled. So, providers sign up. We have had a pretty broad definition of what we mean as a provider. So pediatric primary care providers, but really focused on that provider level engagement. But of course, this is a nested system. Many providers are not sole providers in their practice. And so they are a part of a practice. And in that practice, there are other providers. And many of these practices are connected in other various ways. And so we were able from the outset to leverage those connections at the practice level and regionally in terms of recruiting, but we still enrolled at the provider level. And then kind of after the fact realized, it would be really good to get the practice level information too. And have talked through and tried various things at the practice level in terms of engaging practice level managers and getting data from that perspective. So I think the lesson learned here, and it's so interesting to hear from other states and their experience, is at the outset trying to make a plan and being clear about what you're trying to do, and also being prepared to pivot and recognizing that these are actually very complex systems that are interrelated, and that there's lots of opportunity for data collection, but also it can get muddy and complex very quickly.
Great. Yes, that is one of the, working on the evaluation with you all, the 2018 and 2019 awardees, and now moving into the evaluation, including the 2021 awardees, that kind of distinction between enrolling providers and or practices has been one that's variable across awardees, and how you're engaging with and onboarding those providers and practices has been interesting to see. And it's been great to hear about how you're all doing that. So thank you for sharing, Susan and Melissa, on that topic. Again, I think we've touched on this a bit, but just the importance of collaborating with other awardees and local partners also rose to the top as a theme in the responses that we heard from the 2018 and 2019 awardees. So not only determining what data they're collecting and potentially being able to leverage some of those data, but also leveraging any expertise that they may have in accessing and using health data. So we would like to invite Kelsey Torres from Kansas PMHCA, and again, Melissa, to speak on this topic. So Kelsey, we'll turn it over to you first, and then to Melissa.
Thanks. So the Kansas Pediatric program thought it would have been helpful to review other programs' data collection variables for like their enrollment and consultation line inquiry forms prior to developing our forms and our data base to ensure that we didn't miss anything critical. We ended up making changes and adding variables once things became operational. And kind of like along the way. So we've ended up with some missing data sets or spending too much like staff time trying to follow up and obtain some additional information to try and complete those data sets. So for new programs, like in addition to the HRSA reporting requirements and including all of those points when building out your collection forms in your database, something we maybe should have considered more are some of those other hot topics that are happening in our state, or points for sustainability planning and advocacy activities. So those changes that we made, like the bigger ones, were around the payer source for the patients that the primary care physician was calling on behalf of, and also like history of psychiatric residential treatment, as those are like our legislative hot topics and are often discussed at both like many different levels of our system.
Great, thank you, Kelsey. So really kind of making sure you know the landscape and what's out there in terms of data and what some of the priority areas are to be aware of, it sounds like. And then Melissa, would you like to share from Missouri's perspective again on this?
Absolutely. Thanks, Amanda. Just to echo what Kelsey was identifying, we relied heavily on other states that had already developed and had what we would consider pretty mature CPAPs, accessing their forms, looking at what they collected. And I do think that there has been across states kind of an evolution of the questions that we ask and the way that we ask them. And so I think that is a critical part of developing and was both in terms of when we were originating and kind of evolved as a program and continuing to reach out to other states to better understand their data collection mechanisms. Also, as Kelsey mentioned, I think connecting at the state level with those state level partners to make sure that we are collecting not just data to report, of course, which is very important, but also collecting data that are relevant to other stakeholders. And in particular, wanted to highlight our use of our steering committee. We had regional steering committees, and then as we've moved to a statewide program, now have a statewide steering committee. And they have been actively involved in evaluation really from day one. That is sometimes challenging, to be frank, because our forms and data collection processes do get a lot of feedback and go through multiple iterations. But I think because of that, folks are engaged in a different kind of way in looking at the data we're collecting, tracking it over time. And again, we do have that foothold to get input from a lot of diverse stakeholders, from a lot of different agency perspectives across the state when we're talking about data for sustainability, advocacy, what kind of data will be most compelling to different audiences. And so because we had that buy-in upfront and continue to engage them in that way, I think that we are able to now extend that work in that way now. Thank you.
Great. So it's great to hear about kind of partnerships among groups like this, where you can share existing resources and tips and strategies and tools, but also, Melissa, for you, engaging that stakeholder group to get those multiple perspectives on what and how you're collecting and how it may be used. So thank you for sharing that. Next slide. So a few more things that were addressed in awardees' responses to our question were strategies to promote the program. So make sure you're kind of using consistent messaging and tracking outreach and marketing efforts. We had a few programs who felt that this was a critical element. So we'd first like to invite Christine Walton from Alaska PMHCA to share on this topic.
Hi, everyone. Thank you. My name is Christina Weltzine. I'm from the PMHCA program here in Alaska. And I wanted to share a couple of thoughts with reflection now as we're in year 4. So sort of in hindsight, I think that if we would have spent a little bit more focus and energy in year 1 and 2, really doing promotions of our pediatric access line in a more maybe thoughtful manner in terms of the audience that we're trying to reach, the networking opportunities that were available to us. We would, in hindsight again, probably designate presenters in our internal team, and prep them for, the various audiences that we were addressing. So, our medical director definitely for the pediatricians that we're talking with. We would additionally have our PowerPoint slide decks tailored to our different audiences. So we do a lot of rural outreach to our remote Alaskan communities. And there really is some specific narratives and visuals, excuse me, that I think would have been that would resonate more with some of our rural providers. And so we now have amended our promotional materials so that there are, representation of the audience and the population that we're attempting to reach in some of our marketing and promotional materials. So again, keeping that PowerPoint slide deck updated and reflective of, current trends and adding some data and so on. We now have really slick flyers and handouts, and we have some video links in our promotional material to some previous webinars that we have done. So I think that really working hard initially on, making your program visible, connecting with the champions in your state that can also help leverage your promotion. So for example, our advisory board, what we really wanted to do is recognize each significant role that they play in our state health promotion. And we do ask them to promote our program and make it easy for them to do that with flyers and materials and links and so on. So again, one last comment was closely tracking our outreach. So we were able to construct a map that outlines, the volume of calls and the callers, and represent that by geographical region, so that we can see where we're getting most of our calls, and then we can tactfully market our program to those geographical areas which we're not receiving calls from. And it gives you kind of an inroad to your promotional strategy. So those are a few of our tips in hindsight from up here in Alaska.
Great, thanks so much. So it sounds like really kind of, making that an expectation from the outset, and in the outreach and marketing that you're doing, really making sure that you're tailoring it to the specific groups in your audience to make sure that it's really resonating with them. Great tips. Thank you so much, Christina. On this topic, we also have Wisconsin PMHCA speaking. Wisconsin, I'd like to invite you to speak. I'm not sure who from your team will be speaking. Sorry about that.
Hi, this is Sarah here with the Wisconsin CPCP. I really do appreciate the opportunity, Amanda. Thank you. Piggybacking off of Christina, I think you had some really great ideas about tailoring your message to particular landscape. That was a really great idea. I think we're going to even take that one. But I think maximizing all uses of communication that you're currently using, making sure your website is updated and reflects your services and your outreach, and even like a dashboard that indicates your consults and your educational modules being uptake and other features of that. I liked your Christina's option of updating the PowerPoint and your slide deck. Same with Wisconsin. We've learned to tailor those to where they are in the program, meaning are they enrolling currently? Have they been in the program for a period of time? And so we're also tailoring our slide decks to our participating providers. Sometimes within a conference, you have an opportunity or conference materials to talk more about evaluations and your data collection, e-blasts and your monthly newsletters. If you have the opportunity to expand, there are places to do that in your current forms of communication. And also sometimes personalizing your emails or your e-blasts coming from perhaps a regional coordinator or the psychiatrist that they have a relationship with, and building off of or leveraging the relationships that they have. Seeing that some of these emails or requests for surveys or evaluations come from those that they trust within the program is a step in the right direction to making sure we have a higher rate of evaluations being filled out. Also, again, I really liked Christina's options of video links and getting some of your champions within the clinics or within your advisory committees to pass along information and advocate on your behalf through links, passing along other information through their newsletters. We have recently, we might be late to the game, but your Facebook posts, video links, that type of thing. So really maximizing all forms of communication and relationships that you've built with advocacy within the community, and as well as your primary care providers, clinics. And then we have recently started the top-down approach. We really have focused on working at the clinic level, provider level, but we're really trying to do a top-down approach, getting buy-in from directors, and then trickle down the completion of evaluations, data collection, and enrolling providers that way as well. It's a little bit more work up front, but in the long run, we do have a really good way of getting providers onboarded.
Great, thanks, Sarah. I'm going to turn it over to Susan Hayashi, the project director, to summarize and introduce our next two speakers. So Susan, let you take it away.
Thank you so much, Amanda, and thank you so much, Sarah, and everyone else who presented. I think you can see from the discussions here and what's being shared is really the systematic approach, I'd say, of engaging providers and healthcare professionals and the promotion of the programs. The other piece that I just wanted to highlight, this came up over the past few years, was that with the consultation lines, the calls, that sometimes the health professionals who wanted to call were afraid that they were taking time away from practicing health professionals. So really making sure that you communicate as part of that, you're not taking, calling is not a burden, or reaching out for some of the services or support, because that's what those individuals are, being compensated to be available for that. So that is a nuance that had come up previously. The other piece was having a number of programs develop videos that allowed providers in the state to realize that, oh, these are the types of services, this is who you're reaching out with, so that put the name with the face if you weren't able to do the in-person, as some folks described. So those are just a couple highlights with that, but now we'll move on to considering collecting different types of data, qualitative and from different sources with satisfaction surveys. So I will turn that over to Maryland PMHCA at this point. And I think that's Amy, sorry.
Thank you. And thank you to JBS and HRSA for the opportunity to chat about this. So we have used surveys quite a bit in our first few years of implementation, and have learned a lot the hard way about how hard it is to pin PCPs down to get them to complete surveys. We started with a needs assessment survey to just understand some of the needs in some of our rural areas, and learned there that we needed to fax a lot of things because our PCPs still rely on fax over email, or so electronic surveys are not a thing that they were really a fan of. So that was one of those barriers we encountered. And then more recently, we've used surveys in the context of our tele-echo clinics. And while it's easy to get PCPs to complete the survey to register, it's harder to get them to complete surveys to evaluate sessions and to evaluate their kind of overall experience. In part, we learned that we tried to use the carrot of CMEs, like you can't get your CME certificate until you fill out your survey. And then we came to learn that they don't need to produce those certificates for any reason, at least in our state. And so some of those sort of incentives that we were trying to leverage their participation with were, we found out we were a little bit undermined by that. And so we're just at the beginning stages of considering and preparing to launch some qualitative interviews to understand different aspects of how our providers' use of our warm line services is impacting their practice, and also their perceptions or experiences in some of our other services like our Project Echoes and other kind of training offerings. So we'll be that's probably the next step. I guess the other thing I would say about different sources of data that's maybe less related to kind of a direct research aspect is we've learned a lot about how to figure out who are the practices across our state. This was not a very easy and an intuitive thing. So we're kind of taking advantage of both lots of combinations of publicly available data on providers and practices, which is dirty at best, but also trying to think creatively about a process that kind of ties back into engagement, but also just kind of keeping up to date on where are the practices, who's enrolled in those things by just kind of a systematic, what we call an environmental scan review of the landscape. Those are probably my 2 cents. Thanks.
Thank you, Amy, so much. And I just want to apologize that I accidentally skipped over being able to have Delaware PMHCA speak, and we'll come back to that in just a moment. So my apologies to you, Joe. So I'll move on here to Florida MDRBD, and that's Heather Flynn who will be presenting.
Hi, good afternoon, everyone. Dr. Flynn had another engagement, but I'm Amanda Haynes. I am the program manager with the Florida BH Impact program. We have really done a lot to figure out data collection methods. We've been going for about 4 years now. And of course, as everyone else has said, our methods have evolved. We are a program that is kind of community-based. We're not connected to like an academic or larger health institution. So a lot of our relationships are built kind of from the ground up, but we heavily utilize our consulting psychiatrist who is a staple in one of our regions. And, you know, she did a lot of work in terms of building relationships with the practices that we call the low-hanging fruit. And we do a lot of our data collection focus with those practices because we've built those relationships. So as somebody else mentioned, you know, earlier on, we were doing in-person engagements and we were able to get our self-efficacy survey data through paper surveys. But as we transition to the virtual world and the COVID challenges that came up, we switched to Qualtrics surveys, you know, putting our self-efficacy in Qualtrics and dropping that link in the chat of our Zoom sessions, our Zoom trainings. But we learned that even though it seems easy, you know, it's not always easy to get those docs to click that link and complete the survey. We did find better success with embedding QR codes within the training itself, so that they just pick up their cell phones and they're directed to the survey immediately. We had much better outcome in terms of surveys with that. As far as the program evaluations and the different methods that we use to get those evaluations completed, I mean, again, a lot of it was about relationship building. So we did contact our high utilizers, those folks that call us all the time that, you know, have been engaged with Dr. Russo's, whether it be on a phone consultation or those kind of on the fly hallway, you know, consultations. We engaged with them immediately and made sure that they had a direct email. We would call them or text them and give them the link that way. We also kind of towards the end with those practices that didn't have that much engagement, we emailed the practice provider and said, hey, could you please reach out to these people in your practice and see if they could complete the survey, which we did have some success with that. We also had some success with printing the survey, making a paper printout or a PDF copy of the survey and emailing that. We did have some success with getting those completed. We did do some qualitative work as well, and I'll pass it on to Dr. Dyken Hansen, who will talk a little bit about our qualitative work.
Mandala, thank you so much for that comprehensive overview of our data collection strategies. One of the final pieces that I'll add is that we have implemented some qualitative data collection approaches as well. Our program heavily emphasizes health equity as a core component of our programs. And so we took it upon ourselves to reach out to providers from high utilization programs to talk to them about the ways that they engage their patients during the perinatal period and identify both behavioral and social care needs for their provider or for their patients so that we can better inform and customize our service provision strategies.
Thank you so much. I think you can see the complement of different types of data and how that's beneficial in terms of being able to essentially tell the story of the program. I will turn it now to Sarah Beth Upston from Montana MDRBD.
Hi, everyone. Thank you, Susan and team, for letting us speak today about our satisfaction surveys. So we in Montana were a little bit later in implementing our teleconsultation line, and we're able to learn a lot from the existing sites and also from being a part of the Lifeline for Moms network. And that was really instrumental in us deciding to do satisfaction surveys and seeing how it would go in our state. So we keep them a little bit shorter. We have 4 questions about the provider. Just like date of assessment, their practice organization, provider name, and their email address. And the email address is great just so we can follow up if we need to. But then we have 7 questions that are specifically about the line and about their experience calling in. And these were adapted from questions that Lifeline for Moms, they had talked about at one of their meetings. And we decided, okay, we'll just run with this and create this as well. So, we ask about, if they got a call back from the provider within, a timely manner, and if the teleconsultation line provider was helpful. And the 2 last questions I think are the most interesting are about if by calling the teleconsultation line, they were able to prevent the patient from escalating. And that's a yes/no question. And then the open-ended question, which kind of builds on this qualitative data piece that the other states talked about, is what would you have done if your patient, what would you have done to help your patient if you didn't call the teleconsultation line? And that's really interesting because in Montana, we really don't have a lot of additional resources. And typically the responses we get are they would have waited months to get care. They would have waited months to get medication or therapy. And that's just really helpful as we potentially go in front of our legislature to talk about this, to have those narrative pieces and also contact information for those providers. If they ever needed to go and testify in front of our legislature, that's really important to have. We still have a low response rate. So far we have, of the 45 consultations we've done, we've only had 11 responses to the satisfaction survey. So it's about 25%. So it's around what we have for the self-efficacy survey from providers. So I think we're always going to have providers that don't take the time to fill out surveys, no matter how hard we try. But what we do, the way we send out these surveys, so it was designed through the DPHHS website that we have by our website people. And so they made the website for us. So then I get pinged whenever there's a new response. But the link is sent out by our perinatal psychiatrist when she sends out her notes. So she'll send it out and just be like, hey, please fill out the survey. We need it. It would be great if you filled it out along with all of her notes about the consultation. And not surprisingly, we have a lot of the same providers fill out the survey, like each time they'll fill it out. And it tends to be the providers who call the line more frequently. So, I mean, those are not surprising things. And so I think that there can be some biases with our survey results because we're clearly missing some of the providers who maybe only call once. And, that's just something to consider. But I mean, I think some data is better than no data. And I really think it's very interesting to get the qualitative piece and hear and see that from providers. And I would just recommend, especially if you are thinking about sustainability and how you're going to have to pay for this, having some of that data that when you potentially have to go in front of your legislators is really important. So thank you.
Thank you so much, Sarah Beth. I think that all those components that you've heard, it's being able to think, down the road, what, how the information is going to be used, refinements that you make throughout the time period, but also the sustainability down the road. The other piece that I would say is just, some programs, when they've done a training or depending on how providers are participating, is completing that satisfaction survey right into that time frame. That's so that it's not something they have to do after the fact. So sometimes that's helpful as well. But when you're trying to capture it after they've used the line, that's a little bit different, obviously. So I will go back now to Joe Hughes from Delaware PMHCA. And Joe, if you could share your insights about promoting your program, and then we'll go down to offering incentives.
Thanks, everybody. And thanks for coming back to me, Susan. Appreciate it. And I was really hoping I was going to lead right into my presentation after Alaska and Wisconsin, because they pretty much covered a lot of the strategies that we have used here in Delaware. We've tried everything. We've got email, newsletter. We've even attempted direct mail, which is snail mail to some of you. Face-to-face, we've developed swag bags with promotional materials in them. We've advertised, we've developed a brochure, we've developed a one-page handout. When we first started this, it was all with the intention of going out into the community and visiting with people and actually making face-to-face contact, which has been our most successful strategy. But COVID hit just a little more than a year in, and that really derailed all of our face-to-face activities. We still attempt to do some of those, but no one's holding conferences anymore, so we can't go to conference and hold a table. What I'm getting at is all of these strategies that everyone has already talked about, figure out how to collect the data on how impactful they are for a number of reasons. One, you want to know which strategy is most impactful. You want to know how you're reaching your target audience. You want to know, which strategies are working and which ones are not. Don't waste any more money on the ones that are not. When you want to request carryover funding to expand any of these marketing strategies or to anything like that, HRSA is going to ask you, well, how impactful has it been in the past? So make sure you have your data prepared for all of that. And that's what I'm getting at. That's why it led right into my presentation. Track as much of your marketing and promotion as you can. Find out how your providers are learning about your program, and so that you can use those networks again in the future. One more thing I wish we had learned about, we developed a newsletter probably in the second year of our program that I wish we had identified. Constant Contact is what we went to eventually. We only started Constant Contact, which is an electronic newsletter, about 6 months ago, maybe 7 months ago, and we're able to track every opening of that newsletter, every click on any link. So we're able to count all of the data and how successful each one is. And our newsletter is getting a little bit better and better each month. We're getting a little bit more activity on each one from month to month. So we're looking at strategies on how to continue to use Constant Contact to track the activity on all of our marketing strategies.
Okay, great. Thank you so much. Really appreciate that, Joe. And I think that everyone can see that theme coming through. I'm just going to say we've got about 10 minutes left. We've got 4 presenters, and that'll take us about 5 minutes yet. And then I will briefly talk about the evaluation and also work to get some question and answer in. So I'm going to move right to New Hampshire PMHCA and Erica Tenney.
Thank you, Susan. I'll try to be quick. I know we have a lot to finish here in the next 10 minutes. So At our program, we know that the data collected through surveys completed by our enrolled providers is crucial to our ability to understand our program's impact and effectiveness. So in order to encourage the enrolled providers to complete both our Project ECHO pre and post cohort surveys, as well as the JBS healthcare provider and practice level surveys, we have used a strategy of offering incentives. Originally, we weren't planning on doing that, but in the first year, our first cohort that we launched, we actually were able to access some state funds that were only available that year, but we were able to get some, and we decided to provide some monetary stipends to enrolled providers if they completed our pre and post cohort survey and the JBS surveys. And that worked very well. We had 2/3 qualify and receive the stipend. But unfortunately that money ended. So with our second cohort, we decided to raffle off some very nice logo glass water bottles, something that we had, and that worked as well. We had almost just as well with the survey response. So we've seen that incentives are, at least for our program, being very helpful, and just wanted to share that with you all.
Thank you, Erica. And Wisconsin PMHCA, and that is
Thank you, Susan. I'll take it. It's Sarah here.
Yeah. Oh, sorry. Okay.
Similarly to what Eric has talked about, incentives and monetary value and raffles, we've also looked at, do you put in incentives before or after surveys being completed? And then what does that look like? Intrinsic value, extrinsic value. You have to also read your providers to see what they value. But before, if you were to provide the incentive before and perhaps have it arrive at the clinic personnel can all kind of take part in the incentive, perhaps a gift basket or a fruit basket, and then your name and logo is on it. You receive some recognition, and then the primary care providers that receive the incentive gift basket also gets some recognition, and then the whole staff can also, eat from it or enjoy it, and then there's some intrinsic value from that for the providers who received the extrinsic valued basket, and then that kind of prompts providers to fill out the survey. If you're looking at sending out incentives prior to the surveys being completed. And then a lot of the same tactics that were just talked about would be something that we have done after the surveys have been completed by doing a raffle or the monetary value. We've done Amazon gift cards for completion of surveys. And also a surprise raffle for a larger amounted Amazon gift card, and that was in the amount of $100. The other thing just to be mindful of is, does your grant include or allow incentives? Does your organization allow or allow incentives and up to a certain stipend or amount? So those are things to consider when incorporating incentives into your survey completions.
Okay, thank you so much. And Rachel, I see your question about the amount. You got a little bit more about that. And what we'll do is if we can't get through all the questions, we will make sure that we respond to them in writing. And so just pop your questions in there, and that'll all be captured. But in terms of sustainability, I'll turn it to Christina Weltson from Alaska PMHCA.
Thank you, Susan, and I am watching the clock as well. I just want to mention how much I've enjoyed listening to other states and, hearing some compatible types of strategies, and also hearing a lot of new ideas. So I just really have appreciated this. So just really quickly, sustainability. We put sustainability, unfortunately, a little bit on our back burner when we started. and we're in year 4 or 5, and it has just crept up on us. And it has felt at times really overwhelming. And so as far as kind of lessons learned, just to mention some ideas we wish we had done earlier on, is really looking for champions in the state, in your medical community, persuasive partners, if you will, who are able to, kind of garner the attention that's needed regarding this topic and moving things forward, because it is a dual agenda. I mean, it is multifaceted in terms of all the players that need to be involved, from legislative efforts to of course our medical community, our behavioral health community, our tribal community in Alaska. So we are now really motivated to find our persuasive partners to join us in this effort, looking for alternative funding. We happen to have contracted for some technical assistance, which we're very grateful for. We have spent many hours previously just discussing the topic and kind of going around and around and not really coming up with a roadmap forward. But we now have a contractor who, with a research group that is helping us develop a roadmap for sustainability for our state. And so we're really relieved to have that technical assistance. So my words of wisdom are really to grab onto it in the beginning if you can, and even just building some momentum and energy towards keeping the project moving, because time gets away from us really fast. So thank you for this opportunity.
Thank you so much for sharing that. And to Chelsea Swanson from North Carolina PMHCA, she'll be our last speaker, and then we'll just wrap up quickly. So
I'll keep this short and sweet for you guys. In North Carolina, we actually started having vague sustainability discussions from our very first meeting about what is the NC model for this kind of a program, but haven't gotten very far. And so the biggest things that I can say to focus on are patient outcomes. People really care that you can prove that what you're doing is actually impacting what happens to the patient. Find ways to collect data on that. It's tricky because this is a provider-facing resource. The second thing is find out what your stakeholders care about. We have frequent discussions with our stakeholders and ask them what aspects of the program are most interesting to them, what data really speaks to them, and did they find persuasive. One of the things that we've learned is that our payers are very interested in HEDIS measures, and finding ways in which our program can support practices in improving HEDIS measures has been a really big selling point. So thinking about those types of things. Dipping back to the patient outcomes thing really quickly, be mindful that this is probably going to cost a little bit. I think a few people have touched on this, but and Karen from North Carolina too, dipping into EMRs is not easy and it requires some tech support. So you're going to have to pay for it. So think about your budgets and things like that. But I'll stop there and I'm happy to chat with anybody at any time about either of those things.
Well, thank you so much. And I think some of this in terms of will become themes for future discussions. As I mentioned, we'll make sure all the questions get answered. If you have any existing or remaining questions that you have, and I know we'll revisit the sustainability component as well. If you could go to the next slide, please, and one more. Just we will email this as well, but this gives you the evaluation timeline of what to expect for 2022 and what we've accomplished so far in terms of the instrument development and aligning things with the new cohorts. And then today is the first evaluation capacity building webinar. And then in March, we'll be finalizing the evaluation design. And then in April and May, we'll be having one-on-one calls with 32 of the awardees. And that's by design from our contract. So we look forward to talking with you. And then for the rest of the year, you can see where there'll be some data collection activities, and we're proceeding with getting approval from OMB to be able to conduct the data collection with the new cohorts. And there'll be ongoing evaluation capacity building webinars, as well as some virtual site visits. So we look forward to engaging you and really appreciate all our presenters today. Anything else from HRSA that you would like to cover as we finish up? I will take silence as a no, but like I said, we will follow up in terms of questions. Thank you for posting additional ones in there. And we look forward to connecting with you. So have a great rest of the day.